Ischemic heart disease is a condition whereby there is reduced blood supply to the heart muscle. It comprises of stable angina pectoris and acute coronary syndromes. Acute coronary syndrome is basically a term that describes symptoms resulting from severe acute myocardial ischemia. The ischemia may or may not lead to myocardial infarction, that's heart attack. Acute coronary syndrome is usually classified as ST segment elevation on the electrocardiogram. That's ST segment elevation myocardial infarction, abbreviated as STEMI, or non-ST segment elevation myocardial infarction. That's NSTEMI, and also unstable angina. That's an acute coronary syndrome without elevation of cardiac enzymes. So basically, NSTEMI or STEMI and unstable angina. So the risk factors for acute coronary syndrome are identical to those for angina pectoris, that's stable angina pectoris, and also include previous episodes of stable angina pectoris. The risk factors for this condition include obesity, diabetes mellitus, hypertension, smoking, and hyperlipidemia. Causes include atherosclerosis or obstruction of the coronary blood vessels, leading to reduction in blood supply to the heart. Symptoms are chest pain, which is usually of sudden onset, could be of varying degree but often severe and described as tightness, heaviness, or constrictive in nature, persisting for more than 30 minutes. Not relieved by rest or glycerol trinitrate, and also may radiate to the left arm, the neck, or jaw. Also, symptoms include nausea, vomiting, shortness of breath, or fatigue, and this may be the only presentation in diabetics and also in the elderly. And also there could be loss of consciousness. So the signs that are usually elicited include restlessness and apprehension, excessive sweating, peripheral or central cyanosis. Pulse may be steady, fast, irregular, slow, or even normal. Blood pressure may be high, low, or unrecordable following extensive damage to heart muscle. Also, bilateral crepitations in the chest with left ventricular failure. It could also be presence of a third or fourth heart sounds, which suggests heart failure. And normally in the elderly, there is confusion. Investigations are standard 12-lead ECG, cardiac enzymes, CKMB, troponins T and I, and myoglobin, serum lipid profile, chest x-ray, random blood glucose, FBC, ESR, serum uric acid, blood urea, electrolytes and creatinine, C-reactive protein, echocardiography, coronary angiography too. The treatment objectives basically to relieve distress and pain, to limit infarct size, and also to prevent and treat complications, to reverse cardiac remodeling, to prevent reinfarction, to identify and manage modifiable risk factors, to improve quality of life. Non-pharmacological treatments include reassuring patients and encouraging bed rest in the first 48 hours. Also, encourage cessation of smoking, ensure weight reduction in overweight and obese individuals in the long term. Pharmacological treatment. For the initial treatment on admission, you give oxygen intranasal by face mask or nasal cannula. Also, you give aspirin oral as chewable 300 milligrams stat, and then you add clopidogrel oral 300 milligrams stat, and glycerol trinitrate sublingual 500 micrograms stat, and also morphine IV 5 to 10 milligrams stat, and then you add metoclopramide IV 10 milligrams stat to prevent vomiting induced by morphine. For the maintenance treatment following immediately after initial treatment, you give aspirin oral 75 to 300 milligrams daily indefinitely, and then you add clopidogrel oral 75 milligrams daily, and patients who receive revascularization therapy will require treatment for up to 12 months. For anticoagulation, you give enoxaparin SC 1 milligram per kilogram, 100 units per kilogram, 12 hourly. And then for the prevention of cardiac arrhythmias and reduction of myocardial workload, give atenolol oral 25 to 100 milligrams daily, and avoid only if beta blockers are contraindicated, or you give bisoprolol oral 5 to 20 milligrams daily, or metoprolol oral 50 to 100 milligrams 8 to 12 hourly, and then you add lisinopril oral 2.5 to 20 milligrams daily, or losartan oral 25 to 50 milligrams daily, or candesartan oral 4 to 16 milligrams daily. And then in patients with STEMI, as ST segment elevation myocardial infarction, you give fibrinolytic agents. So fibrinolytic agents may be given as reperfusion therapy in patients presenting with ST segment elevation myocardial infarction under specialist care, and manage acute complications such as pulmonary edema, cardiogenic shock, and cardiac arrhythmias. Also manage hyperglycemia with insulin. So change diabetic patients previously on oral hypoglycemic agents to insulin. For long-term treatment as secondary prevention, you give aspirin oral 75 to 150 milligrams daily indefinitely, and also you give atenolol oral 25 to 100 milligrams daily, and avoid only if beta blockers are contraindicated, or you give bisoprolol oral 5 to 20 milligrams daily, or metoprolol oral 50 to 100 milligrams 8 to 12 hourly. So to prevent cardiac remodeling and improve survival, you give lisinopril oral 2.5 to 20 milligrams daily, or losartan oral 25 to 50 milligrams daily, or candesartan oral 4 to 16 milligrams daily. Avoid ACE inhibitors and angiotensin receptor blockers in patients with BP less than 100 millimeters mercury. To stabilize the clot and reduce blood cholesterol levels, you give atorvastatin oral 20 to 40 milligrams daily, or rosuvastatin oral. For rosuvastatin oral, you give 10 to 20 milligrams daily, or you can even give simvastatin oral 40 to 80 milligrams daily. And statins are indicated irrespective of lipid levels. Also, to improve coronary dilatation and also reduce myocardial workload, you give isosobide dinitrate. Okay, so for isosobide dinitrate oral, you give 10 milligrams 8 to 12 hourly, and also control hypertension and hyperglycemia if present. Referral criteria: all patients with suspected acute coronary syndrome require an urgent ECG. So if ECG is not available or cannot be interpreted, refer immediately to a higher facility. Patients with confirmed ST segment elevation, myocardial infarction in any facility should be referred urgently to a physician specialist or cardiologist for reperfusion therapy, as after an initial oral dose of 300 milligrams of aspirin. So other patients with NSTEMI, that's non-ST segment elevation myocardial infarction, and also unstable angina, should be referred to a physician specialist or cardiologist after initial management, as mentioned.